So good evening, everybody, and thank you for taking your valuable and precious time today, this evening on Saturday. Really a very warm welcome to all of you who have joined today. It's going to be a very special seminar today as we are going to have a very interesting speaker, an old colleague of mine, an excellent pediatric oncologist with more than 25 years of experience. And I will be giving a thorough introduction of him. But before that, I'd like to tell a little bit about the company, where we come from and what we intend to do. The name of our company is SigTuple. And as you know, we combine robotics, optics, and data science to bring about pertinent solutions in pathology. These are some of the exciting things that we have in store, in fact, for this coming year. Our flagship solution was the peripheral blood smear analysis on an AI-based platform. That's where the whole journey started from. And the problem that we wanted to actually address was the inconsistency and the inaccessibility of reaching out to patients, and also across borders. The thing is that as pathologists, we all know that we have to be in the lab, dependent on the microscope next to us. And here we have an AI-based solution on a cloud-based platform. And all you need to do is run your peripheral smear into it. And the AI-based assistance that is given to the pathologist brings down the turnaround time. And you have a visual-based evidence as well, which gives the confidence to the pathologist, making the whole process more efficient and more accessible and more consistent. So as we all know, peripheral blood smears are the area where we start our diagnosis from when it comes to hematology. Although we're going to be talking about oncology today and hemat-onc and a bit of flow cytometry and case studies with Dr. Intezar is going to be showing us today. It all starts from the peripheral blood. It starts from a CBC, and that's the foundation. Until today, that's how we practice as pathologists. I think we are morphologists from inside, deep down, and we depend on the peripheral smear and the CBC findings, which then guides us to take the relevant steps, in order to make the most accurate diagnosis. So the blood samples come into your laboratory, it goes into a hematology analyzer, which obviously flags a lot of, situations which are mandates for you to actually make a peripheral smear, which you stain and then see under a manual microscope. Now, there are a lot of issues with this. You need to be available next to your microscope all of the time. And it's a very time-consuming, fatigue-driven process. So a little bit of inefficiency is definitely out over there when you are looking at that. Is my screen visible, Daka, or has it just gone? Okay, there we are. So a little bit of inaccuracy and inefficiency when it comes to that. And largely, we're trying to address it with our solution, which is known as AI100 device, which is powered by Shonit. And what's the most interesting fact with our device is that not only can you do the peripheral blood smear, you can also do the urine microscopy. But here today, we are talking upon hematology, and that's where we're going to be sticking into. So I'm not going to be dwelling with the urine microscopy out over here. So this is what our device looks like. It's got a very simple case, and you can see the screen out over here. We have a robotic arm that actually comes out where you can place the peripheral blood smear. There's a camera and an optics inside this particular device. The optic scans the peripheral blood smear. The camera captures the images, puts it up on a cloud-based platform, and where the AI-based algorithms actually compute and give the visual-based evidence along with the AI-based results to the pathologist, which the pathologist can view from any internet-enabled device from anywhere in the world today. That's how simple this whole mechanism is. So this is how, the routine peripheral smears that you make in your lab. We are stain agnostic. You can use any of the Romanowski stains, and you can use any of the slides that you have in your lab. So there, we don't really actually recommend any particular glass slide. It's just the dimensions should come in the standard size, which can enter into the device out over here. And you can use your own stains as well. So there is no other miscellaneous item or consumables that you need to put into extra while actually running it into this device. And what we give you is the 7-part differential. We give you the RBC morphology, the platelet morphology, and also the microscopic view, which gives you a seamless transition to move from manual microscopy to a digital microscopy-based reporting. The similar thing is for the urine microscopy as well, where we give you a cartridge where you can actually charge this little micro chamber out over here, and then you do not need to centrifuge the sample, and the device will be able to read out the cells and give you the report with the classification and the semi-quantitative grading as well. So it makes it very simple for the pathologist, because most of the 80-90% of the work is actually done. All you need to go look at the images, look at the AI-based results, and approve the report within no time. And all of this, trust me, can be done within a minute or so. We are CE certified, as well as we have got the FDA as well for the Shonit solution, which is our peripheral blood smear solution. We have the CE mark for the urine solution as well. And as you can see with our comparators in the industry, we have double the throughput. We have 2 solutions on 1 device. We are less than half the cost, and we have better accuracy as well. So what makes it very interesting is the visual evidence-based reports, and that's so important as morphologists and even for a clinician. And I think Dr. Intezar later on would agree with me on this. Seeing is believing. When we give diagnosis as a pathologist, I think even the clinician would like to look at those images today, and seeing that gives a lot of confidence to them as well, that on what basis are we actually arriving to a particular diagnosis. And that is very easy with a digital-based system like the one that we have out over here. So you have the WBC, RBC, and the platelets, and you can see that we give you the semi-quantitative grading for RBC morphology as well. This is according to the ICHS guidelines. We give you the grades for microcytes, macrocytes, round macrocytes, and oval macrocytes, and also the poikilocytosis, which includes most of the common poikilocytes that you actually see today in your peripheral blood smears, and all of that with visual evidence again. The similar thing can be seen for platelets. In platelets, we actually give you the platelet count, and we actually give you the platelet morphology as well. So it's like a total blood smear report. That's what you kind of get out over here. And the most important thing is that the similar thing, you can see it here for urine as well. You have the summary of the report here with the parameters in the urine. You have the results of it with the grading as well. Semi-quantitative grading for urine microscopy is for your RBCs, your pus cells, as well as your microorganisms, and the rest of it is detected versus non-detected. You can see that there is no staining required here. There is no centrifugation required out over here. So all of this is great, but what really makes the whole solution stand apart is this microscopic view. And I think this is the comfort zone for us as pathologists. We want to see the smear ourselves. We want to go around and scan the smear ourselves and see whatever is the area of interest. And this is very remarkable because you get that 40x, you get a zoomed in option as well to 100x, a rollover zoom, and all of this is very user-friendly. And once you start looking at this, you really don't miss the microscope, because this is the feature that actually gives you that seamless transition to move from manual microscopy to a digital-based reporting, as you can see in the system out over here. The similar microscopic feature can be seen for urine microscopy as well. So it's just that the software changes from Shonit to Shrava, which is from peripheral blood smear to urine microscopy. And all of this today is a very smart way of reporting. And what appeals to me the best is that I can use this on the run, whether I'm in a conference somewhere, I'm not in the country, and I'm traveling somewhere. And if a second opinion needs to be given, to a junior pathologist who's back in the lab, it makes it very easy for me to see it from any internet-enabled device. I can see it on my iPad, I can see it on my laptop, I can see it on my smartphone today, and I can give the necessary instructions that are required and give the diagnosis within no time. So coming to today's topic is going to be about ALLs and the advancements which have been happening in the remarkable field of pediatric hemato-oncology, and Dr. Intezar is going to be addressing all of that today and enlightening us on the different things, on the aspects of like the latest clinical achievements that have happened, the personalized, targeted the therapies that have been happening in the field out over there. Even I'm like really waiting out here to see what he can really share with us today evening. AI100 can also diagnose leukemias. As you can see, the blast, it picks it up with great accuracy with the visual evidence and the clarity. If you can see in the images, you can see the fine chromatin, the conspicuous nucleoli, and not to mention you have the microscopic view as well with the magnified zoom. Why I put up this slide today is that while it all sounds very complex, the answers still lie in the right approach. And by the right approach, I mean, it starts from your peripheral blood smear reporting. So even though we have advancements, in molecular and flow cytometry and all of that, right? The very important thing is the peripheral blood smear. It starts from that. You get a lot of information. You get a lot of clues to see what you are actually looking into. And then you're correlating with the clinical history. I think Dr. Intezar will again second me on that. How important it is to know about the patient, the clinical details provided by your clinician. It is very important to have a good rapport with your clinician so that you get all these details before you actually start seeing the case. And once you get the clues from seeing the case, you move on to the further evaluations, which helps you to either confirm the diagnosis or do other evaluations, which leads on to the next step so that you do not miss anything. And, you kind of corner in on to see, what your differential diagnosis is. And then finally, what is the diagnosis? And there are many pitfalls when it comes to us as pathologists. When we see a peripheral blood smear, sometimes you see blasts like this. You don't know they are myeloblasts or they are lymphoblasts. And that's in adult leukemia in itself sometimes can be very challenging. But when it comes to pediatric, it's even 100 times more tougher. Sometimes you get very tricky cases. Dr. Intezar will be sharing a case or two. And you can see how he explains about it and how those challenges are actually met. And especially in pediatric marrows, when you come across things like hematogons, which he will be explaining about, and that's where the distress is, for a pathologist. Are you dealing with blasts? Are you dealing with hematogons? And then you're doing a flow cytometry. What are the features that you would see if it is hematogons? Do you see a typical waterfall kind of appearance that you're seeing in the graph out here today? Or are you seeing something, more localized cluster, which you are doing further markers on to confirm whether it's myeloid or lymphoid? And again, in lymphoid, is it BALL or TALL? So there's so much that comes to it, right? But again, to remind you, it starts from the peripheral smear interpretation. Then it goes on to marrow, and then it goes on to flow cytometry and all of that. And during all this time, during my experience, at least as a hemato-oncopathologist, it's very important to be in sync with what the clinician is thinking. It's very important to keep giving that information at every step in time so that, even they give their guidance, right? And it's a double dialogue. It's a two-way dialogue between the pathologist and the clinician, and which helps finally to arrive at the right diagnosis. And so this is what we're going to be talking about today. Overall, AI, where it really helps is for higher pathologist efficiency by improving the turnaround time. It gives you a standardization. It gives you reproducibility. It brings about an elimination of the biasness and the ambiguity of the human mind. There are times, in the lab, you say that, I can see 50 cases, I can see 100 cases. But then beyond that, there's a certain amount of fatigue. And by evening, we had this dialogue that, the slides aren't really talking to me and I need to see it fresh the next morning. So I think AI to a large extent really helps to take away the mundane cases as well, where you can focus on the critical cases and use your energy and your, the brain space to look at what is more critical for your patient. And definitely it's more cost efficient. It can be used for research and last but not least for training and teaching purposes as well. Now, I don't want to take too much of time. I want to move on to our special speaker today, Dr. Intezar Mehdi. We have been colleagues for a very long time. I've known him personally for more than 20 years, and we work together in HCG as well. He is the director right now, the head of the department and senior consultant of the Department of Pediatric Hematology, Oncology, and BMT, HCG Hospital, Bangalore. The rest of the information is there put up for you. For me, I think he's a very passionate oncologist. He's somebody who would just get down to the depth of it. And, even if he has to stay back in the hospital, as long as required. And, he's very approachable. I think that's another very great quality of him. You can always approach him to discuss the case in detail. And you can see the academic achievement that he has achieved both at national as well as international platforms. His areas of interest has been hematolymphoid malignancies, leukemias, and lymphomas in particular. And also he's started the thalassemia clinic and an expert in bone tumors, both solid tumors as well as BMT as well. He's a reviewer in many national journals and international journals, life member of many chapters, as you can read out over here. faculty and program director, fellowship in pediatric hematology, oncology, and BMT. I think the list goes on, Dr. Intezar. So, I don't want to take more time out over here. I'm going to give it over to Dr. Intezar, welcoming you today and taking the time out and to enlighten all of us with the advancements that have happened in this field of ALL. And what better than you to hear it from you today? So welcome, Dr. Intezar, over to you.
Yeah, thanks, Dr. Renu, for the humble introduction. And first of all, thanks to you and your colleagues and your company for giving me this opportunity to be here this evening. As you rightly said, technology is moving rather very rapidly in the last 10, 20 years. I think it has gone from what used to be the standard of care to be something of the past. And in the next few minutes, we are going to see that how treatment, approaches in management of childhood leukemia has changed considerably in the last few years. If you have stopped sharing your screen, then I am able to share. Yeah, done.
I've stopped.
Yeah, thanks. Are you able to see now? You are able to see my screen now?
Yeah, can you go on to the slideshow mode? Yeah.
Right. Okay, perfect.
We're good to go. Yeah.
Yeah, can you hear me and can you see me as well? Yeah, okay, we're done. Uh, so incidentally, February was the World Cancer Day, and the theme for this year, 4th February, was United by Unique. And this actually emphasized the importance of personalized patient-centered care. So very rapidly, we are changing from what used to be evidence-based medicine to personalized treatment, meaning that one size fits all no longer holds good and every patient or every individual has a specific need. Similarly, on 15th February this year, it was International Childhood Cancer Day, and like every year, this year the theme was promoting awareness, improving access to treatment, advocating for increased research funding. So this is a global collaborative campaign which is trying to say that not only the awareness but also access to treatment, and every child has to get a chance to get cure from the childhood cancer. And we celebrated in our center the International Childhood Cancer Day by having some kind of fun activities, some magic shows, some drawing, coloring, painting for children. Now, the first thing which comes into our mind is how common is cancer in children. And fortunately for us, it's not that common. It's about 38 to 124 cases per million children in India. Probably, are we lesser than the world or US? Probably not, but probably be due to underdiagnosis and underreporting. To make it simpler, the incidence in our country is about 1 in 10,000 children. Fortunately, it's less than 5% of all cancers. But then, as we know, our country has a population of close to 145, 150 crores. 30% of the population in India is below 15 years. So it's about 50 crore children are at risk. So, you can imagine how many cases will be diagnosed every year. And if you look at the data, about 20 years ago, the published data said that the childhood cancer cure rates was dismal at less than 30% in our country. But fortunately, now it has improved because of better access to care and better understanding the disease process and more publications coming up. And now in our country also we can aim that 70 to 80% of childhood cancers are getting cured. And we talk about cancers in children, leukemia, lymphoma, and brain tumors constitute about two-thirds of all childhood cancers. Similar is the state in our country as well as in the West. And then bone tumors, retinoblastoma, abdominal tumors, soft tissue sarcomas, and others, make up the list. And then, so when we talk about cancer in children, as we just saw, there are different types. We don't see breast, uterus, ovary, lung, or colon cancer in children. The disease biology is different. But cancers are more aggressive and they have more acute presentation, but at the same time, children, because they do not have comorbidities like diabetes, hypertension, IST, and so on and so forth, majority of the time, the treatment approach is also very aggressive. We are going with a curative intent. We just don't aim at 5 year disease-free survival. We are just aiming for long-term survival with good quality of life. And obviously, the outcome is excellent if they are managed well. This is one of my favorite slides, which I put it up in across in almost all my presentations. Just goes on to show the success story of pediatric oncology. As you can see, in the last 50 years, from 1970 to 2020, you can see there has been a tremendous, improvement in the cure rates. And this particular graph showcases the cure rate for childhood ALL, which was dismal at less than 10% about 50 years ago, and now it is close to 90%. And similarly, as you can see, most of the cancers in children, about 85% of them can be cured, and ALL almost tops the list, along with a little bit of Hodgkin's lymphoma and Wilms tumor, which have cure rates of more than 90-95%. In spite of all this, every 4 hours a child still dies from cancer, unfortunately. And the moment I put up this slide, childhood is a precious time of everyone's life, and we all just go back to our sweet memories. And imagine if child is diagnosed with cancer at this point of time, it's very important for us to make sure that even during the treatment, the child continues to enjoy the childhood, because that time is not going to come back. Now, majority of the time, hematological malignancies, especially leukemia and lymphoma, most often they'll be present to the general peds person. And many of the times, the signs and symptoms are subtle, like fever, pallor, pain, lymph nodes. And it's very important to pick them early and prompt referral to the specialist center. High index of suspicion is very important. And we always say in cancer, first time is the best time, meaning that right treatment at the right time at the right place will go a long way in curing. And the impact is much more when we are treating with childhood cancer, because it's not only on the impact of the child, the family, siblings, grandparents, relatives, financial implications, social implications, education, because the child is future not only for that family, but also for the society and also for the country at large. So the stakes here are much, much higher. Like Dr. Renu mentioned in our introduction, it's a multidisciplinary team approach majority of the time, and we have to take so many people into account. Child with cancer is right at the center, along with the family and school. It's not just the pediatric oncologist who is treating. There are surgeons, radiation oncologists, medical social worker, nursing support staff. Very important. The lab personnel, hematopathologists, blood bank, teacher and art therapist, psychologists, so on and so forth. And make sure that the treatment given is with a lot of love, play, and determination. Now, it's a big question, which often, at least for the students, if they've joined here, why do children get cancer? As we all know, 95% of the time, we do not know what is the reason for the childhood cancer. And only 5% of the time, we may have some implications like genetic syndromes like Down syndrome, other chromosomal genetic abnormalities, exposure to ionizing radiation, which could be accidental or from radiation or from radiotherapy that has been linked to previous treatment. Rarely infections, for example, EBV-associated lymphoma, especially Hodgkin's and non-Hodgkin's lymphoma, and HIV-associated cancer. So when I talk about cancer in children, it just follows a particular age. As you know that majority of the time, preschool children, children below 2, 3 years of age, neuroblastoma is the commonest cancer in this age group, and then retinoblastoma and LIMS. And in the middle childhood, children start going to school by 4, 5 until about 15 years of age in this age group. The most important cancer in this age is blood cancer or acute lymphoblastic leukemia, followed by acute myeloid leukemia. And then when you have adolescents, there is a big growth spurt, and along with that, it coincides usually with the bone tumors, germ cell tumors, and lift of Hodgkin's lymphoma. So let's come to our topic for today, which is the leukemia or the ALL, simple in children. As you can see, there is a male age preponderance, and most of the children affected are between the age group of 2 to 10, and most of them are between the age group of 2 to 5, which is the peak age, and a slight male preponderance. And majority of the time, the classical presentation in children have unexplained fever. There can be bleeding, bone pains. There can be hepatosplenomegaly, or there can be spleen alone, or lymphadenopathy. Sometimes there may be weight loss or poor appetite. So these are all classical presentations. If you have a child presenting with fever, pancytopenia, organomegaly, lymph nodes, almost always we'll pick it up. As Dr. Renu mentioned in her introduction, CBC is our window, and that's the most important test which is ordered upfront, and it may show various problems like child may have anemia, bicytopenia, or may have pancytopenia. They may have leukocytosis with a lot of blasts in the peripheral blood, or they may have low count, no blast in the peripheral blood, but only cytopenia. And then we do a bone marrow examination for confirmation, which shows the abnormal cells. Let's quickly move on to some interesting cases. This was a 4-year-old girl who presented to us about 5, 6 years ago. Was well till about 2 weeks before, then had some fever with decreased oral intake. She was seen by a pediatrician. Some treatment was given. There was partial improvement. Then the fever reappeared. CBC was done, which shows platelet of 30,000, hemoglobin 8. WBC is 2,567% lymphocytes. It was suspected as dengue, managed with platelets, PRBC, antibiotics, and support. Now the question here which comes is, would you consider this as dengue? What are the differentials and how would you proceed further? I mean, there's no rocket science here. All of us would agree that since there is such significant anemia along with thrombocytopenia, I think dengue is not in our differential upfront. We all know that platelets can drop with dengue and WBC also can drop, but usually there is a hemoconcentration. A hemoglobin is very unlikely to drop. So if we were to be seeing this child, we would not manage as dengue and probably do, think of other causes. So repeat CVC showing pancytopenia, fever has subsided, seen by another pediatrician. That pediatrician referred the patient to me, and this is a stable child with some pallor, no lymph nodes, no organomegaly. We repeated the CBC. As you can see, platelets have improved to 1.2 lakhs. Hemoglobin is 6.9. WBC is normal at 4,000, but there is relative lymphocytosis. PS is showing some cytopenia, but there are no abnormal cells. What would you do next? Well, we went ahead and did a bone marrow examination with flow cytometry, and not to our surprise, because we always knew that this kind of presentations are there, 60% blast, pre color positive, ALL. So simple, straightforward diagnosis on the flow cytometry. Further, later we got the karyotypic cytogenetics and molecular reports, which are all normal. Child received chemotherapy as per UKLN 2003 regimen A, did very well. She has finished maintenance chemotherapy and she is off treatment now, back to school and doing well. So the lesson we learned from this presentation is viral infections are definitely a common cause of low platelets and sometimes WBC. Dengue is an important differential diagnosis, but low hemoglobin, unless clearly nutritional, it's a red flag. He is by an experienced hematologist, somebody like Dr. Renu. And when in doubt, discuss and probably consider doing a bone marrow exam or refer to a pediatric heme on upfront. So, as we all know, in the past, diagnosis used to be based on morphology, FAB, L1, L2, L3 classification. And nowadays, we all know that it is based on the immunophenotyping or the flow cytometry, 4 color, 8 or 10 color. And we are able to classify which type of leukemia we are seeing. And then there can be immunohistochemistry on bone marrow biopsy. And then we order other tests like karyotyping, molecular tests. And nowadays, NGS has also come up in the big way, which I'm going to speak in the next few minutes. Now, as Dr. Renu was mentioning, it's very important to distinguish the hematogones from blasts, both at the time of presentation or those patients who have had treatment for leukemia, especially after induction or other phase of chemotherapy or post-bone marrow transplant. So hematogones are usually a normal immature B lymphocyte precursors in the marrow. They are part of the normal development of B cells, which are crucial for immune system. They are distinct lymphoid cells with condensed and homogeneous chromatin and scanned cytoplasm, and usually on the immunophenotyping they lack any aberrant expression and they have a characteristic spectrum of antigens. Okay, on the contrary, blasts are usually immature and usually they are cancerous cells, particularly in leukemia. They can resemble hematogones upfront morphological when you look at them, but careful evaluation is very important because they will have an indented nuclei with fine chromatin and variable nucleoli and surrounded by deeply basophilic cytoplasm. And then maturation arrest is there and they exhibit the characteristic aberrant immunophenotypic expression that deviates them from the hematogones. So this is the picture. You can see characteristic B cell ALL, where bone marrow is showing several lymphoblasts with a high nuclear cytoplasmic ratio and various variably contains nuclear chromatin. And B cell lymphoblasts on the picture B are showing coarse eosinophilic granules. Similarly, on the T cell, you can see T cell lymphoblastic leukemia. The lymphoblasts are vary in size from large cells to small cells, very high nuclear cytoplasmic ratio. Bone marrow biopsy is also showing increased mitotic activity in the lymphoblasts. So usually flow cytometry will be able to give us a clear-cut answer whether we are doing it with a B cell ALL or a T cell ALL. And sometimes we are doing it with a mixed phenotypic ALL or a biphenotypic ALL. And the characteristic features in the infantile ALL, especially if the children are below 1 year. So we use the various markers. As you all know, the B cell markers, the most important ones are the CD10, 19, 34, 45. And then you have the T cell markers, which is most important ones are the CD3, 2, 5, and 7. As you can see, 6 color tubes or 10 color tubes will be there. This is a simple diagram which is just showing how the characteristic features of flow cytometry in BALL. You can see that lymphoblastic lympho to moderate CD45 expression and low side scatter, and then B lymphoblasts are expressing CD19 and CD10. And on the lower left, you can see CD79A and TDT, And on the lower right, you can see that they are expressing partial CD34 expression. So you have a patient with a B cell AL. Then when you do a karyotyping, we are able to see whether we have a normal karyotype, or we have hypodiploidy or hyperdiploidy, or we have a complex, karyotype. And this has very important prognostic significance. And then sometimes on the karyotyping, you pick up Philadelphia chromosome like BCR ABL, or you pick up the ML gene rearrangement, which is now called as KMT2A, 11q23, or the tele-ML, which is translocation 411. So the molecular test, in addition to karyotyping, most of the centers will order either a PCR-based or FISH-based leukemia panel. You have leukemia panel, or you have the separate ALL panel focused one, or the AML panel. And nowadays, a lot of centers have started doing the NGS-based evaluation of the molecular tests. Now, move on to another case. This is a 4-year-old boy with fever on investigation at a local hospital, found to have bicytopenia. Hemoglobin is 9.2, platelets are 90,000, WBC is 12,000, occasional atypical cells. We went ahead and did a bone marrow, but unfortunately, it was a dry tab. As you can see, we are not able to see anything on this. We went ahead and did the flow on the peripheral blood, even though, as you can see, the cell count was very, very less. Dr. Renu, would you mind explaining this flow report so that the audience are able to understand it better if it comes from you directly?
Yeah, sure. So I remember this case, Dr. Intezar, and when you had highlighted this case to me when it happened. And most of the times, what happens is the challenge that we get is we get a dry tap, and we resort back to the peripheral blood to see if we can do a flow on it to help the clinician, arrive at a certain diagnosis. And that's what happened in this particular case as well. So if you see the blast, actually, generally you know that it's a blast population because, as Dr. Intezar mentioned also, you get a dim CD45 expression and they're low on the side scatter. Now, the next thing, I'm already thinking whether it is, if it is a pediatric, peripheral blood, I'm thinking, could it be an ALL actually already in my mind? And I put on the markers. And so these were the markers that were, which were put at that particular point of time. And you can see that there were 19 positive. You're looking at the B cell markers out over here. You have the color positive CD10 as well. And you can see that the myeloid marker was actually negative, which is 117, as well as your 33 and your 13 out over here, and your 14 as well. So already like kind of coming to a conclusion of B cell expression out over here in this particular case. So yes, we did conclude on a color positive BALL. So we're very lucky to get a very easy diagnosis out over here. So over to you for the next, the cytogenetic report.
Thanks, Dr. Renu, for a very crisp, explanation of that flow. So we were able to diagnose this child with B-cell lymphoblastic leukemia, and incidentally, the karyotyping revealed that the patient was having hyperdiploidy, which is a good prognostic marker, and 4-year-old and low count hyperdiploidy, B-cell ALL, and negative for BCR, ABL, and AML. So standard risk patient did very well with treatment. Now, what's important is sometimes these leukemias may have an atypical presentation. For example, many children with ITP, immune thrombocytopenia purpura, may be mistaken. So, if you have any subtle signs of anemia or leukopenia or clinical examination showing any lymph nodes or organomegaly, that's a red flag. And especially if you are planning to start steroids in an ITP patient, consider doing a marrow. Similarly, many times we have seen patients presenting with JIA or JRA, juvenile idiopathic arthritis, where bone pains or joint pains is going on for a very long time. There is some cytopenia, marrow is not that steroids are started, and the diagnosis is missed. Like you can see in this case, this is a very complicated case. 5-year-old boy is having high-grade fever associated with bone and joint pains for almost 6 weeks. Seen by pediatrician, blood test is done, nothing there. Symptomatic treatment given, child symptoms have not subsided. Child is again shown to the pediatrician, blood tests were repeated. This time certain abnormal cells were seen in the peripheral smear. Then he was referred to the hemato-oncologist. But like it happens so often in our country, unfortunately, the parents took the child for alternative treatment. And few days later, symptoms persisted, so child is brought to a pediatric oncologist. Peripheral smear is done elsewhere. It is reported to have some blast with leukopenia. Next day, bone marrow is done. Unfortunately, it's hemodiluted. No opinion possible. It is repeated again, but unfortunately, no opinion possible. Then the family has gone back to alternative treatment again. And few months later, down the lane, they came to us with the above symptoms, no definite diagnosis. Clinical examination, nothing remarkable. OP-based evaluation, we did routine blood test, X-ray, ultrasound, abdomen, TLS panel, or normal. We also ask for EBV, DNA, PCR. So initial evaluation is showing lymphocytic lymphohistiocytosis cytosis with few typical cells. What we do now? What are the possibilities now? Now, he was noted to have, as I mentioned, leukocytosis, some atypical lymphocytes, small insignificant lymph nodes, hepatomegaly, and bone pains on follow. So we decided to do a PET scan before doing a bone marrow because we wanted to see what are the other areas where disease might possibly be there, whether we are dealing with a lymphoma or a leukemia kind of diagnosis. On PET scan, he had metabolically active lymph nodes, bulky kidneys, hepatomegaly, and diffusely active marrow, suggestive of some kind of lymphoproliferative or bone marrow infiltrative disorder. So we decided that under sedation, we went ahead and did a lymph node biopsy, kidney biopsy, as well as bone marrow biopsy. Because we thought if we just do a bone marrow, we might not get the diagnosis because this patient was something like partially treated or something. And as you can see, PET scan is showing a lot of disease. So on the bone marrow biopsy was negative, but the lymph node and kidney biopsy showed B-cell lymphoblastic lymphoma, stage 4 disease. Probably this was leukemia to start with, and because of partial treatment has become like this. We treated the patient like a B-cell lymphoma stage 4 with BFM-based protocol and HRM. Finished treatment, back to school, doing well, no issues at all. And you can see the PET scan showing fantastic clearance just in about 6 weeks' time post-induction. So this case highlights the need that even though a differential of hematolymphoid malignancy was suspected, it was not picked up on initial evaluation. Alternative treatments, especially steroids, may mask the picture, and even when diagnosed, the outcomes may become inferior. So, what is the standard of care presently? As you can see, that all ALL patients, we need to do a very good risk stratification to classify them into standard, intermediate, and high risk. Protocol-based management, aggressive supportive care, and MRD, minimal residual disease, which we are going to learn in the next few slides, and collaborative efforts. So as you can see in this slide, traditionally age, WBC count, immunophenotype, genetics, CNS, and MRD, these have been the criteria to classify the patients into favorable, intermediate, and unfavorable, or standard, intermediate, and high risk patients. Out of this, the most important thing now is the age, WBC count, genetics, hyperdiploidy versus hypo, and MRD, which is the end of induction MRD, whether it is negative or positive. So as you can see that the different groups have a little bit of difference in the risk stratification system. The NCI highlights mainly on age and WBC count. That means 1 to 10 years are standard risk, and anything below 1 and more than 10 are high risk. And WBC count less than 50,000 versus more than 50,000 is categorized as standard versus high risk. But if you the BFM group, their cutoff is age between 1 to 6 years and WBC count is 20. They also emphasize on the good prednisolone response, and all T cell ALLs go into high risk arm, and they are not treated on the standard risk arm, obviously. And then you have unfavorable cytogenetics and other things getting incorporated. Now, if you see the UKNL, it is more elaborate. It does have age WBC count similar to NCI, but extramedullary disease is also considered as high risk feature. Response to induction therapy, that is also considered as a very important feature, and unfavorable cytogenetics, especially hypodiploidy, MLL gene variant, and IM21, they are associated with high risk. ETV6 and ANNEX1, which is a favorable cytogenetics, KM2A, also considered as high risk because they are associated with infant leukemia. And MRD status, those patients who are MRD negative versus positive, we actually classify them into standard and very high risk. So it's very important to stick to one particular, protocol, because there are subtle differences between protocol to protocol. Now, as you can see, that ALL is a very heterogeneous disease. You have cure rates in excess of more than 90%, especially in hyperdiploid ALL and tele-ML ALL. And you have a dismal outcomes in patients right at the bottom of the picture. You can see 30% odd in patients who are infantile leukemia, especially with MLL gene variant. We all know that the ALL treatment actually focuses on what is called as induction, consolidation, and maintenance. Induction is for the first 4 to 6 weeks, and consolidation is next 4 to 6 months. The first month aims at achieving remission, deeper remission, and consolidation aims at removing the remaining cells which have been there, and maintenance aims to prevent disease relapse. Almost all protocols incorporate steroids, vincristine, anthracycline, and aspergillase in induction, followed by cyclophosphamide, cytarabine, 6-mark-apteperin, and methotrexate in the consolidation phases. And these are the various contemporary protocols. It's important that each center sticks to one particular protocol because they are all comparable when it comes to outcome. And in the UKLL, we follow this roadmap, how to classify the patients into which group they are going to go. The child is below 12 months, then they go into interfant. Mature BLL goes out of the protocol. PCR ABL patients or MLL G3 or hypodiploid or IM amplification, they go into regimen C, and those patients who are more than 10 years go to regimen B, and those patients who are more than WBC count also go to regimen B. If they are not, then they all go into the standard risk regimen A arm. Now, in the last 20 years, considerable progress has been made in the MRD, and this is a beautiful paper which was written by David and et al. In 2024 in Cancer's Basal. And this talks about MRD in leukemias and actually how we've learned from APML. APML was the first disease where we were able to evaluate MRD based on the TCR base. So this paper actually talks that we all know that in induction, our goal is to eradicate the leukemic cells below 10 to the power of 9 so that they are not cytotoxic detectable. And complete remission is defined as absence of circulating blast in peripheral blood and no signs of extreme disease and less than 5% blast in marrow. And but we all know that even though patients achieve morphological remission in the past, they were relapsing at some point of time later, and this led to the hypothesis that some kind of disease actually persisted, which we were not able to probably identify because we did not have technology at that time. And then over a period of time, flow cytometry based MRD came into vogue, and now recently, as you know, PCR and NGS based, MRD monitoring has come, which we are able to actually have deep molecular remission by treatment, and we are able to monitor progress on these patients. So to summarize, MRD has been a big game changer. In addition to age, WC count, cytogenetic response, response to therapy, and detection of MRD at the end of induction. Now, MRD is the most important independent prognostic marker in ALL, and we all know that there is nothing called as minimal residual disease. We are able to detect something that means it is measurable residual disease. What we were not able to detect in the past, we are able to detect now with the newer technologies, because up to two-thirds of children may have MRD detectable after induction therapy, depending on the biological subtype and method of detection. It's only that what method we are using at this point of time, because even those patients who have MRD-based flows are negative are also relapsing at some point of time. So deeper molecular remission is required. And this has been the history MRD assessment tools with the year of implementation. As you can see, in the 70s, we used to do morphology, and we used to find out if there are less than 5% blast post induction or not. 80s, we were able to do with cytogenetics, at least for those characteristics, for example, BCR, ABL. 1990s, up to 2000, we are able to do with flow cytometry 10 to the power of minus 3 and 4. And again in 2000s, PCR based, and in future, I think 2000 onwards. And now the future is going to be with NGS based, where we are going to assess up to the 10 to the power of minus 5 to minus 6, so that we are able to detect, disease when we thought that it is not detectable, but there is a measurable residual disease which is still remaining, which actually the patients relapse later. And in 2022, in Kansas Basin, again, there was a paper from the BFM group where they actually incorporated MRD based risk stratification. And as you can see, in addition to their usual criteria, they also started doing MRD at time point 1, that is post induction, time point 2, post consolidation, and time point 3, that is day 78. So you can see that if those patients who had MRD negative at day 15 and day 33, they obviously did very well. And those patients who had MRD positive at time point 2, they did not do well. And especially if they were MRD positive at time point 3, that is post consolidation, you can see their cure rates were in the range of only 33% versus 90, 80, 90% for those patients who achieved MRD negative. This was a landmark paper by Weinberger about 25 years ago in 1998, time, which actually first emphasized the importance of MRD. And this showed that patients who had high MRD did not have a prolonged relapse-free survival, as you can see on this graph, which is highlighted in the pink. And those patients who had low or negative MRD continued to do well, and they had a long-term survival. Similarly, now in 2017, there was another paper which actually compared the flow cytometry based MRD with PCR based MRD. And further, in 2013, this UKLL Professor Vaskar Saha, Professor Ajay Vora and group, they actually published their results for UKLL 2003 protocol, where young adults with low risk ALL defined by MRD, and they showed that patients who were MRD negative, there the treatment could be actually less intensified, And the patients who were MRD high risk, the treatment has to be intensified, that means shifting from regimen B to C. And this is a beautiful paper in 2024 in Blood, which is by Mofli et al. And this talks about how I use NGS in MRD to plan approach and prevent relapse after transplant for both children and adults with ALL. And I would recommend the people who join this group to please read this paper because it's very interesting. And now US FDA has given marketing, permission for clonoSEQ assay for monitoring. So this graph actually shows that how sensitive the NGS is. It's going to be 10 to the power of -6, and it's going to be very applicable because more than 90% sensitivity. It's very, very sensitive. The only problem is that as of now, it's very expensive and it's going to have a very long turnaround time. So for now, most of us are doing multicolor flow cytometry based this thing. qPCR for fusion has a less applicability, but qPCR for IGTR genes some centers are doing in future. I think. Now, what about the history of treatment? As you can see that ALL, like I showed in the beginning, before about 1970, the cure rates were unfortunately less than 10%. That is the global data, not just in India alone. This MCP 841 protocol was in the 1980s by a group of doctors in Tata and Kidwai, and you can see that they used simple prednisone, vincristine, L-aspartame, Dono, and intrathecal methotrexate and 6-MP. The doses here were much lesser than what we use now in BFM or the UKLL group. But this protocol actually showed in various studies that they were able to achieve at least about 60% cure rates for children. As you can see, this is one of the papers from Dr. Akhil Kapoor from Department of Oncology, Delhi State Cancer Research Institute, Delhi. And this showed that about 60% of the patients can still be cured with MCP 841 protocol. But then the West is at 90%, we are at 60. So obviously, we have all shifted to using either BFM or UKLL based protocol. And we have been understanding now that earlier CNS was a sanctuary site. Almost all protocols used to incorporate cranial radiotherapy. Now moved away from cranial radiotherapy and we intensify the treatment by giving either high dose methotrexate, capizi-based methotrexate, intrathecal methotrexate, and most of the patients can get away without radiation to avoid the long-term toxicity. Better risk stratification, better management with the collaborative working groups has been instrumental in changing the cure rates. And now in 2025, we can proudly say that about 95 to 98% of the patients attain remission for ALL, and 85% of the patients aged 1 to 18 years are expected to be completely cured. More than 90% of them are alive at 5 years. In UK, the published data says that more than 90% of children with diagnosed ALL will survive. And in India, fortunately, now we can say proudly that many centers are able to touch the 85-90%. Overall, as a country, we are moving in the right direction and we have long-term cure rates in the range of about 65 to 70% in some studies showing higher cure rates. And this has been possible because of improved supportive care, more precise risk stratification, personalized chemotherapy, and a bit of target therapy and collaborative efforts. So, in summary, we are able to cure about 80 to 90% children with ALL for treatment and up to 95% in certain subgroups. And sometimes these children may present with oncological emergencies like febrile neutropenia, severe mediastinal or completion syndrome, bleeding diathesis or tumor lysis syndrome. It's very important that these kids are actually stabilized prior to transfer. Sometimes we have to discuss with the center where we want to transfer, like you are a pediatrician in the periphery, you encounter a child with one of these problems, it's better to stabilize the child, talk to the pediatric oncologist before you transfer. Because sometimes, we may lose out them out in transfer. So that's very important. Why should you spot a child with cancer? Does earlier diagnosis lead to better prognosis? Well, yeah. As you can see, this is one of the children. Dr. Renu was working with us that time. This was a child who presented to our OPD, sick child. You can see 13-year-old with T-cell lymphoblastic leukemia, huge mediastinal mass compressing the airway. Child is quite sick, facial swelling, plethora, sinuses, and immediately the same child, we had a diagnosis and then started the treatment initial first week with BFM based on steroids. Same by 1 week after the initial treatment did very well. He's long-term survivor and he's doing very well. Now, lastly, let's talk about relapsed ALL. As we all know that almost 80 to 85% of children with ALL will be cured, but 15 to 20% will relapse. So relapsed ALL is the fourth common childhood malignancy we call them as. And now with the current contemporary protocols, we are able to cure only 50% of them. And this is a beautiful paper by Jasmeet Sidhu and her team. And they are talking about relapsed acute lymphoblastic leukemia in February 2024 paper. they say that only about 50% of the patients are, controlled or cured, and the high time that we start incorporating immunotherapies and cellular therapies. This is a little bit older paper, about 15 years ago. You can see the BALL class, only 50% of them are salvageable, TALL only 30%, and infantile only 20%. Can we predict who are the patients through lab failure who are going to do well versus not do well? Yes, to a large extent we can. Site of relapse, length of first complete remission, immunophenotype. That means if the patient has relapsed at bone marrow versus combined versus isolated extramedullary will do well. Timing is very important. Early relapse, that means less than 18 months from diagnosis, they will have a poor response versus late relapse, which happens more than 18 months from diagnosis. And the immunophenotype BALL is fares better than TALL. So these are the three most important factors. So as I mentioned, these three factors plus what is the somatic or genetic alterations and what is the prior therapy the patient has received. This will decide how the patient is going to do. So if you classify the patients into low risk, then they may get away only with chemotherapy and site-directed radiotherapy. Intermediate risk patients will require chemotherapy and probably will require transplant. High risk patients will require transplant, and that is where RT or investigational agents will come. And then there are multiply relapsed patients where definitely, immunotherapy and CAR T cells and investigational agents will come. And this is how, the clones actually change. At the time of initial diagnosis, we may have a different clone. And at the time of relapse, either the minor clone changes, it was polyclonal or a new clone may actually come. The risk stratification systems are also slightly different between the groups, but essentially, the timing, the site of relapse is what is important. So as you can see in 2012, this is a paper from Locatelli et al. This was put up in Blood. You can see that patients who have bone marrow relapse, and if it is isolated versus combined, especially if they are standard risk, that means more than 6 months after stopping treatment, they can be treated with chemo. If they are MRD negative, just chemo alone. If they are positive, allotransplant. And those patients who had isolated bone marrow relapse, if they are high risk, then all of them proceed to transplant. And those patients who are eligible for transplant, we used to choose either a HL identical sibling. If no HL identical sibling is there, then affiliated donor versus cord blood versus haplotransplant used to be the norm. Now, reinduction chemotherapy options until few years ago, we had the option of either BFMR, RES protocol, COG protocol, or the UKL R3 protocol. R3 protocol clearly showed that mitoxantrone was better than the idarubicin, the R3 protocol, and 3-year overall survival was 69% in the mito group compared to 45 in the idarubicin. This is the flow map. As you can see, most of the standard patients will go with the consolidation intensification. They don't require transplant. All the high risk patients will end up getting transplant, and the intermediate risk patients will end up getting either chemotherapy or transplant depending on the MRD evaluation at the time point one. And the results of this paper, both ALL-R3 and ALL-RES BFM 2002 clinical trials, this is for the relapsed ALL. And as you can see, the comparison, the UKLL-R3 has a 3-year progression-free survival of 65%, overall survival 69, about 240 patients. ALL-RES patient for 540, 5-year survival of 60, 69, and COG group. So as you can see, all the groups in about 60%, they are able to give either 3 or 5 years event-free or progression-free survival. So many patients require BMT, high-risk infantile ALL, ALL with reduction failure, ALL with unfavorable cytogenesis, high risk, and relapsed ALL, especially early, very early, and T-cell. So what are the strategies we are using in BALL? We are using reinduction plus novel agents, for example, glinatumomab or inotuzumab. And those patients who require allotransplant very early disease, they will require pH positive ALL. We are moving towards the era of TKI plus reinduction. And in TALL, majority of the patients are requiring nalrobin based treatment, and all diseases are guided by MRD. So you can see what is the difference in the next 12 years. Now you see in 2024 how we treat the ALL relapse patient. Now B cell ALL relapse will get 4-drug induction, early or late MRD. Blinatumomab will be incorporated right here, and then these patients will proceed with transplant. Those patients who are MRD negative will just get chemotherapy. Similarly, in the patients TALL 4-drug reinduction, and then the patients will go into early phase trials with nalrabin and transplant. Similarly, the patients isolated CNS relapse will also get either chemotherapy or transplant. So, in summary, ALL at relapse classify them into standard high risk. All high risk patients reinduction chemo and then proceed to transplant. In standard and intermediate risk, based on the MRD evaluation, decide if the patient can be salvaged with chemo alone or will need transplant. Now, a lot of papers have come with bortezomib-based chemotherapy, which is, from our adult colleagues in myeloma, they use bortezomib so extensively. And the papers have shown, like this paper in 2012 showed about 22 patients here, B cell of 20 patients, and about 16 of them, about 80% of them had a good response to bortezomib-based induction. So this was incorporated into the similar arm, like with Dox and prednisolone, and bortezomib is given 1.3 milligram per meter square day 14811 along with the PEG. And this was in 2019 paper, about 135 patients. You can see 103 BALL and 22 at TALL, all were children. And you can see that CR2 rates were about 68% for BALL. Impressively, even TALL had a 68% response rate, which is quite excellent. On the next paper is trying to evaluate whether instead of we add mitoxantrone along with the bortezomib and what's going to happen. The results of this will come, but a short 10 patients they have done, which showed 80% response. We are a little bit concerned because it may have more toxicity because you are combining mitoxantrone also with bortezomib. Then next is the T cell ALL. This was the first paper, Nelrabine based paper, 26 patients T cell ALL. This was the adult paper initially, and they showed that Nelrabine given at the dose of day 135, 1.5 grams showed response rates of over 30%. Subsequently, this paper came up where children, Nelravine etoposide and cyclophosphamide was used either give chemo first followed by Nelravine or vice versa. And this out of 7 patients, they saw very good response in about 5 patients. Now the era is of immunotherapy and a lot of monoclonal antibodies like naked antibodies like rituximab and conjugated monoclonal antibodies. The most important example, inotuzumab, BITE with that bispecific T cell engager Blina, and then the CAR T cell therapy. And this cartoon very nicely summarizes how this target of immunotherapy are going to act at various levels. And this was a beautiful paper, MRD in immunotherapy, which actually highlighted that how for MRD positive ALL therapies such as Blina and inotuzumab can achieve MRD negativity, and then those patients can actually proceed to transplant, and MRD can be used as a surrogate endpoint. Similarly, MRD-directed immunotherapy, both for Blina and inotuzumab, earlier used in treatment protocols, may obviate the need for stem cell transplant in some patients and is being incorporated, and CAR T is coming up in a big way. Now, Blina has been a big game changer. We all know that this is a bispecific T cell engager antibody. It is an anti-CD19, and this is indicated approval for from 2014, about 11 years ago, for both adult and children for non-Ph positive B cell ALL. And this is used as a continuous IV infusion for 28 days, and it causes side effects. Most important thing is the CRS and the neurological toxicity. And this was the first paper which actually published phase 3 study, phase 3 tower study, which was actually adult patients with relapsed refractory BALL. And this showed that when compared to standard of care like FLAG-IDA, there was significant improvement in patients who used Blina. Subsequently, the pediatric paper was published in 2020, which was the Rialto trial. And there also they showed that the patients who received Blina-based treatment, they did really well. Further, the Rialto expanded access study, Franco Locatelli and group, and this paper also showed that this was very well tolerated, and about 80% of the patients, 70-80% of the patients had 1 year survival, and most of the patients proceeded with transplant. Subsequently, more and more papers are coming up, as you can see in 2021. Both Blina and inotuzumab are being used in relapsed refractory B-cell ALL, and this group had patients from 0 to 25, and most of them were multiply relapsed patients. And they had about 27 patients in this group, and almost half the patients received Blina, and the other half received inotuzumab. Relatively well tolerated, and it was used as a bridging therapy, and most of the patients underwent transplant after this. And this was a big paper from Franco Locatelli and group again in 2021. This had about 113 children. It was a retrospective study, and this was used before the approval and compassionate based program expanded access. And they showed that overall about 59% of the MRD positive patients proceeded to transplant. Median disease-free survival was about 14 months. Median overall survival was not reached. So significant improvement. Similarly, inotuzumab also there have been various papers. Now, for those patients where there is no access to inotuzumab or brillantumab, we continue to use clofarabine based on this paper, which showed significant improvement, as you can see in 2011. And also now in 2023, this is a meta-analysis of clofazimine in acute lymphoblastic leukemia, even as a monotherapy or as a combined therapy, continues to show some 30 to 40% response. And now venetoclax, we all know venetoclax role in AML, but there is a paper recently, about a couple of years ago, venetoclax and navitoclax with chemotherapy in patients with relapsed refractory ALL, and this is also showing about 60% responses in this heavily pretreated population. And flag IDA regimen continues to be there, but the salvage rates with this regimen used to be about 30 to 40%, and now with better molecules available, I think that is going to be the future. Lastly, the CAR T cell therapy. As you know, this utilizes modified T cells to eradicate tumor cells. We take the T cells from patients, cells are genetically engineered to express CD19 targeting CAR, and then, patient is given some kind of, small malablative conditioning kind of chemotherapy to create the space, and then these CAR T cells are injected back into the patient, infused back. And these were the two cars which were approved at that time, 2021. This is a beautiful paper. Are CAR T cells better than antibody or hematopoietic transplant in BLL? And this was the first study, Ileana study, pediatric patients, where they showed a very good response for patients, about 70%, 80% response rates. And this further Ileana study showed that those patients who are 321 multiply relapsed patients, many of them achieved CR, 12-month survival was about 50% and 76% overall survival. So, but many patients in the Ileana study did not go on to get transplant, but subsequently we saw that some of the patients, they lose out the CAR over a period of time, and those patients relapse early. So that's why many patients started bridging over to transplant, and then nowadays, there are papers to say that it's better to transplant the patients and use the CAR T as a bridging therapy. So this table beautifully summarizes that where should we use GLINA, where should we use INO. So if you have a very heavy disease, then it's better to use INO. If you have a MRD positive disease, then you can use GLINA. The patient is heavily pretreated and not very fit for heavy chemotherapy, then use CD19 CAR as a bridging therapy. But the time taken to do the CAR is a problem, and this shows there are so many trials which have been done in labs ALL. You can see how many molecules are being tested. I was really surprised when I was doing this presentation. These are the trials in GLINA, inotuzumab, and these are all the trials for CAR T cell therapy which are going on all over the world, and published results. So, what is the status of CAR T cell therapy in India? Fortunately, we can be proud to say that we have made significant strides in CAR T cell therapy in our country, and we have the first indigenously developed therapy, ImmunoAct, and second one, Immunoil, which is offering good treatment for children here. So right now we are waiting for DCGI approval. It's approved for use in adults, and in children we are waiting for approvals. The paper from the this ImmunoAct was from TMH along with IIT Mumbai, and they showed very good results, about 67%. And similarly, another one, Immunoil, this was from the Bangalore-based biotech startup, and they showed very good response rates in adults and children, and pending for approval for children as of now. So as you can see that fitting CAR T cell therapy in current treatment paradigms, everything has a role. Uh, so now the approach is you have to find where you have to fit the blina, where to fit the INO, where to fit the bone marrow transplant. So multi-research team approach, because everything has a role. And I think in future we are going to have MRD directed, personalized treatment. So this is the transplant data from our country. We've done about 25,000 odd transplants, adult and pediatric about 6,000. And as you can see that this is the transplant data from our center, 400 odd patients. This is our unit where we do our work, and the BMT unit, 9-bedded, state of the art, and we do all kinds of hemato-oncology, transplant, solid tumors. These are some of the publications from our center. These are the recent awards, and this is my beautiful team without whom I wouldn't have been able to do what we have been doing at our center. Thank you for your patient hearing, and if there are any questions, I'll be happy to take.
Thank you, Dr. Intezar, for the very exhaustive and extensive oration on acute lymphoblastic leukemias, the cutting-edge therapies, personalized treatment. Definitely, it was very, very informative, and I'm sure for everyone out here as well. We would like to take some questions from the audience. If there is anything, please let us know. or if anybody would like to share their experience on acute lymphoblastic leukemias in their practice or anything at all on the pediatric front, it's a forum where you could share something from your side as well. We would be sharing the video of today's seminar, and we would be distributing it to all the people who have registered and unfortunately who have not been able to attend the session today, and also to the people who have attended the session today. So in case you want to go through all of this information and get back at a later time and reach out to Dr. Intezar, we would be happy to have you, connected with him as well in future. So Dr. Intezar,
Thanks, Renu.
yeah, I personally felt that it was very optimistic to know about the cure rates, which we are actually hitting here in India, close to about 90% as it is in the international places as well. And that's something so good to know. And the amount of advancements that have actually happened makes it even more exciting, to go on, whether you're on the diagnostic front or, as being on the treatment side as well. It's so it's really so good to know that today that we are able to conquer this and bring out such transformation in the lives of children today. And as we know how difficult it is in the pediatric scenario to actually curb the disease and to bring about the treatment and to get positive rates of survival, it's definitely a great eye opener to see the kind of options that we have in treatment today as well. And that's something I think a lot of us as pathologists and clinicians, it's so important to be updated with the recent advances to know as to how to actually manage and, have the right approaches when managing cases like this. Thank you so much for your talk today. It has been indeed a treasure trove of information that you have shared with us. And we will definitely be sharing the video to everybody who has registered with us today. And we'll definitely get back to you with questions if we do get at a later point of time.
Thanks.
Yeah.
Oh, thanks, Dr. Renu. I hope I was able to do justice to the opportunity provided by you,
Absolutely.
because there is
Yeah.
so much of ocean of information now in the treatment of ALL. Like,
Yes,
as you
that's right.
saw, it has changed from being just with chemotherapy, and that for relapse also we have so many options. We have so much target therapy, immunotherapy, we have CAR T. Um, Unfortunately, many of this treatment is very expensive, and many times, funds are the biggest challenge in our country. And I think that's a separate topic, and you
Yes,
know it very well since you are now kind of AI-based business model as well. So you know how to generate the funds and how to help the patients when they are having financial problems, and how to get the molecules on compassionate basis and all that. Those things are also a bigger challenge. But then, yeah,
absolutely.
outlook is better now. We have been able to reach from what used to be less than 30% about 20 years ago to close to 80% in our country. And then even in relapsed ALL, almost most of the patients used to end up getting only palliative care in the past. And now we are seeing patients even with second relapse coming back for active treatment, because we have so much options available, and we might be able to, cure some of them even from that group. So that's very motivating. Yeah.
Right, right. So thank you so much again for taking your time on this beautiful Saturday evening, and wishing everybody else also out there to have a great evening ahead. Do get back to us with questions, and we would be very happy to help you out with answers for the same. I would also like to
Thank
thank
you.
Mr. Manohar
Yeah.
Daka from my team for relentlessly, going ahead with all the communications and sending the Google Forms for registration, as well as sending out the Zoom link as well, and for being able to host this meeting here for all of us here today. Thank you, Daka, so much. And thank you, everyone, for whoever
Thank you.
participated in today's session. Thank
Thank
you
you.
and
Bye
goodbye.
bye. Have a great evening. Have a great weekend, everyone. Bye.